wrapping up the documentation for 2016. So the kind of expectations with this webinar is, as far as the E&M components, you know, we're going to go through things at a pretty basic level, but I'm really going to try to weave a lot of information as far as risk areas and things to look for, and certainly ICD-10. So as we go through the information, please ask questions through the panel if you have any. And I know we've already had a few pre-questions that were asked, and so as we get to those sections, I will gladly address that. So with that, go ahead and look at our agenda today. So just a few things on ICD-10. This is not really going to cover a whole lot on that, but I did want to make mention of a few things that I think will be helpful slides for your health system, your coders, your compliance folks, so I'll share those with you. We'll cover E&M criteria, looking at some issues in EMRs and certainly risk assessments. We'll review time-based services and how that relates to different things in a clinic versus a hospital, and certainly overriding evaluation and management components. We'll look a little bit about ancillary staff and scribing and how that integrates into EMRs. We always like to cover a little bit on incident 2 and shared service, and I'll even talk a little bit about how that weaves into the PASS guidelines for residents and teaching guidelines. And then I did include a fair amount of slides on industry news and trends, and we may not get to those, but we will, they'll be attached in your handouts, and so you can share those and read through them. So we'll go ahead and get started. So ICD-10, moving forward, I guess I can say that I'm hoping that everyone had a fairly smooth transition into this. I know, especially with our clients, you know, it's just been a lot of learning. We've all been taking all the great training that's been out there, but now we're putting it to use. And so, you know, it's a little bit of discovery over the next 3 months just to see how everybody's responding to it, how our systems are working, and certainly how physicians are changing documentation patterns based upon this new information. So I think it's important to note, and I have a couple of links here that you can go to at some point, but just talking about the audit status now that we're in ICD-10. You know, CMS has said that they are not going to be auditing for a full year after implementation, and so I think the important thing about this is that we really need to use this year as a grace period and a training period for providers, coders, health systems, et cetera, and really the burden being on providers just to understand what additional things need to be documented in order to create that laterality to an I-10 code. And as you all know, there's many that map and there's many that don't map. And so, but I think this is important. When we have reached out to clients and they've reached out to us on just audits, this is a real helpful piece of information, and it just, I guess, helps you a little bit in creating strategies over the next year to have a lot of education going on in different resources. And so, again, a good link to look at. And a couple things that we're doing as a consulting company is, you know, not only do we provide training, but we also do a fair amount of auditing from the past to the present. And so I wanted to give you one of our strategies that I think has been really helpful to share with providers as far as, you know, what they've been doing and how that can be improved. And we have found that the more familiar you can make this in comparing to their own documentation, the more helpful it is for them to say, okay, this is what I've been doing for years. This is how my templates are written. What do I need to do more of? And so I've given you some steps here to create what I call a reverse audit. So, you know, this is something that compliance coders can do, but, you know, pulling history for the top ICD-9 codes by specialty, and then using those top codes to link into past claim history. You know, from there, trying to draw a correlation to a specific claim to not only pull that information, but pull the documentation on it. And then from that point, you know, trying to map out to an I-10 code. And some of these may directly map based upon what they have, but some of them may not. And really keeping in mind the fact that at some point, you know, through different documents, CMS said that, you know, at some point they're not going to be paying for unspecified. And although, you know, there are these codes contained in the I-10, there's a lot more detail that can be utilized to avoid those. And so, in any case, this is a really nice way to develop some structured feedback to providers and keep a log of all these different codes, and so that you can, again, have some sort of a visual tool for them to refer to when they're dictating or writing in their EMR or whatnot. So in any case, this is just a good way to think about an audit moving forward. We have lots of different strategies, but this has been one that we've used that's been really helpful. So I just wanted to throw those two slides out as part of my I-10 piece. But we're going to dive into evaluation management just because we do have limited time today to go through things. So just going back to our general principles, and these principles are going to be more important than ever moving forward as far as just documenting a visit. The reason for the encounter and the relevant history and how that ties to a physical exam, test results, and then finally coming up with your assessment and clinical impression. And so, we're going to talk about just different things that can happen within these areas to ensure that you're painting a full picture. Not only to justify the medical necessity, but certainly to tie into the whole I-10 piece. I always like to start my evaluation management section with just talking a little bit about authentication, just because we do a lot of different types of audits. Some are pre-bill, some are post-bill. And every system, every EMR has a little bit of a different way to authenticate. Certainly depending upon if your physician is typing in the EMR versus if they're dictating and get information back to review and then authenticate. But the most important thing is just making sure the correct provider is on the documentation and that it is properly authenticated. There's a link down below to talk about the best ways to authenticate and what is actually valid. And we've gotten a lot away from the eligibility issues since EMR have come into play, but we come into new issues with just the pending and revised, or maybe somebody else signs it before a physician has to if they started the note. So there's lots of different scenarios that take place with this, but it's always a good thing to just revisit it to make sure that that is working well. So a couple things with the evaluation management section, especially starting with the new and established office visits. And so we'll talk about these a little bit more in depth as far as just the criteria. But as far as satisfying the new patient, most important, you have to have all three categories, meaning one of history, exam, and medical decision-making in order to even suffice one of the evaluation management codes. And the only thing that can override that is the counseling documentation criteria, which we'll go over just a little bit later. So, and probably more important is, the definition. So, sometimes we will encounter health systems where they have multi-specialty groups, and maybe the physician sees the patient for the first time in the hospital as an inpatient. And then they follow up in the clinic, and oftentimes we'll get asked, well, once they come to the clinic, since they're new to our clinic, what happens at that point? Well, if that internal medicine provider had admitted them, and then they follow up in the clinic, this would be an established visit to them. If they came to a different specialty that they haven't seen within the last 3 years, that would be new to that specialty. So again, that can be a little bit confusing when you integrate all these different specialties, but certainly an important point to mention. As far as established patients, they only have to meet at least two of the categories of history, exam, and medical decision-making. And from our perspective, we always choose one of medical decision-making, just because if you look back on a lot of CMS communication, and especially through the MAC, they always say that medical decision-making, really trumps the visit. And we'll go into some more things about that later. And again, this criteria can also be met with a 50% rule for counseling and coordination of care, but we'll visit that just a bit. For the initial and subsequent visits, so this has changed also a bit since we got rid of the consultation code. So an initial hospital can happen anytime a patient is admitted. And again, if they are admitted on the 1st of the month and released on the 3rd, and they're admitted again on the 5th of the month, this will always be an initial hospital for that very first visit. For consulting providers, they're also using the initial hospital just because we don't have the consultation codes to rely upon. And so you have the different categories between the two. And then I put a little notation there about the AI modifier, and this would be designated for the principal physician of record as far as denoting that, so the payer knows who admitted the patient and who maybe all of the consulting providers are. So that's an important little modifier. And then any subsequent visits thereafter, whether by the consulting or by the admitting provider, would be again this two categories of history, exam, medical decision with the same information from the previous slide.
Hey, Jana, this is Lee. Sorry to break in. Hey, just
yes.
though we've had a number of folks note that the audio keeps fading in and out. Do you think maybe you need to switch to your handset or something?
How's that?
Good.
I'll go ahead.
It was both good on my end. But... All right.
I'll go ahead and
Let's
take
try
it
it this
speaker for
way,
you.
and hopefully it'll clear up. Thank you very much.
You betcha. So as far as the chief complaint or the reason for visit, this is the very first thing when going into a new patient visit or an established patient visit or a hospital visit that should be documented. And so really this is the reasoning for having that visit today, whether it's medically necessary, whether it's a screening visit or whatever it may be. So again, CMS has a pretty specific definition, a concise statement that describes symptoms, problems, condition, diagnosis, or reason for the patient encounter. Now, this doesn't have to be separate and distinct from the history of present illness. Oftentimes when we've done audits and, we find this as a part of the history of present illness, but it is a very integral and important piece, and certainly from all the documentation guidelines from I-10, these are really nice concepts to share with your providers to say, these are more things, that we can add to the chief complaint history present illness, which we'll go over a few things here shortly, just to have them amp up that piece of the documentation and, again, provide a full story of what's going on with that patient and the background behind it. So let's go into history of present illness, and this is really the first piece of the history documentation. And again, we've seen this standalone, we've seen this added with the chief complaint. So either way is just fine. Unless your MAC sets out a different standard in the states that we've worked in, that has been not an issue. So a couple things here on my bullet points. The history of present illness should clearly show development of a problem since the last visit. And so for anything that's been established, it's good to, again, just that interval history of the patient's following up on a problem, what's happened since that last visit. And then any new problems that happen as within the visit today, should be clearly identified as new, and that will absolutely weave into the medical decision making at the end. So those are really important points right there. We like to pull a lot of QAs from different MACs into our webinars just because I think it helps to clarify, what they're thinking and certainly their guidance on things. So this is kind of an interesting one. An RN or NP obtained a history of present illness and documents it. The physician then goes over the information with the patient to verify it. Can the physician say, I verified the HPI with the patient, please the RN NP documentation above? So no, as far as narrating is concerned, the physician must gather and document the history of present illness themselves. There are certain pieces that ancillary staff can go over. And so as far as like the nurse practitioner, that's different maybe as a shared in the hospital environment. But if it's an MA or an RN, there's just certain things that they should be documenting in the record. And the physician certainly should be doing their piece of that. So as far as just the correlation of the record, anything that is in the history of present illness should really float down to the exam and the assessment and plan. So, really when we look from an audit perspective and we go down to the assessment and plan and we see a lot of information as far as things that they're managing that are not mentioned in the history of present illness, we really have to question pre-populated areas or historical things of that record that maybe should have been placed in different areas. So The no correlation is very important, and certainly with ICD-10 will play even a bigger role as far as just all these different pieces and parts that have to be documented as a part of, some of these detailed areas. So here's some more detail on the history of present illness as far as the elements. And, this is a great area to share with your providers to say, as much information that you have at the time for this patient in these different areas, whether they can describe, the quality of the problem that they're having, the duration, the timing, all these different things are certainly going to be key in building that picture, for coding. So in any case, I gave you some examples there to be able to share. And as far as the second component of history, that's going to be your system review. And there's different trains of thought as to, what actually is a complete. And I have a couple of slides here. We often see in the auditing tools that we use that a complete is defined as 10 systems. And I know that there's been various MACs that have said we want it documented one way or another. And so I think the message here is just to ensure that you're checking with your MAC to see how they prefer this to be documented. So certainly you can, keep your physicians informed and everything be in compliance. There is a slide, I think it's the next one right here, and this is actually found in the Claims Processing Manual, Chapter 12. And interestingly enough, in that second paragraph, a comprehensive history must include a review of all the systems and a complete past medical, surgical, family, social history obtained at that visit. And if you look at documentation tools, and I guess I can specifically say maybe the Marshfield Clinic template, there are 14. So this is why sometimes it says 10 for some MACs and 14 for others. We always recommend 14 if they're coming up with a complete. And again, just so that it speaks more to this slide, and that kind of bulletproofs their documentation. And certainly, if it's not necessary to do a 14 system, then I always tell them not to do it. It's really up to them to figure out, what the patient needs and for that physician to make that decision. But if we are helping health systems to develop templates, I'll usually have them put the 14 in there. The last piece of the history is past family and social history, and this is pretty self-explanatory as far as these areas that are required. Just a couple of things that I think are important to mention. In some of the MACs that we have worked with, and you can see Noridian again down below there, they had a Q&A back in 2011 that addressed this whole thought of non-contributory. So just really educating providers to stay away from that lingo if they want to count it as a part of their overall history, because again, some of the MACs feel that if non-contributory is documented, that really it didn't have anything to do with today's visit. And so, if there's maybe nothing found but it was reviewed, there's other ways to say that. So again, that's very important. And certainly in the area of social history, sometimes in audits we'll see things like patient presents today with grandmother. And that really doesn't give us that age-appropriate review of what's going on. And so, again, if you see things like that that really don't speak to the medical necessity or the pertinence of that visit, and it's counted as social history, that's another area that's a really good one to go through with your providers. So there's two sets of guidelines that can be used, and typically we will audit from the 1995 unless the system has specifically said that they use the 1997. So it's really up to the provider to decide what is going to benefit them the most in that respect. As far as just the different levels, and again, different MACs will differ on how they want you to count these. So I'm going to speak from the Northwest in our states as far as just what they require. I know that there's a 4x4 method. There's all different kinds of methodologies, and so again, this is one of these things where you just have to kind of figure out what is pertinent to your MAC and go from that guidance. But I think the most important piece is the comprehensive level. And just because for the 1995 guidelines, it's going to be organ systems. And so this is one of those areas that, although they may document body areas and organ systems, really it's counted off organ systems. And so that's really important. One of the things that we have found with a couple of the EMR companies that we have worked with is the background calculation of examination when they have their encoder turned on. And we had a client several years ago, and they were a specialist. They were actually ENT, and interestingly enough, they had a really lovely documentation template for their examinations. And they always would say that we go off the 1995. Well, when we started to look in the background of that, interestingly enough, the company had put in the 1997 bullets for the different areas for them to document it, but the front side of the system was counting it as the 1995. So it wasn't using the 1997. So it was very much mixing apples and oranges, which unfortunately had overstated all of their examinations. So anytime we go in to work with a new client and they have an EMR, that's one of the things we always like to look at is to know the background of that EMR and how they count information, because exam is one of those things that's a little bit more objective, but certainly when you get into HPI or medical decision making, that can be things that are more subjective. And so oftentimes we will tell people to turn those off, but it's just something to think about as you're doing auditing or certainly training your providers in this area. So kind of the same thing as the history area, just the use of the word unremarkable, no different than, with that other history piece that we talked about. If there is a finding, it's better to state it or say normal. But again, there have been information, documented by different MACs to say that they don't want to use this. And so I think, again, it's just being really in line with their expectations and how they look at some of these schematics. Let's move to the last part of evaluation management, which is going to be your complexity, okay? And complexity is always the hardest part to explain when I'm out with providers, just because the way that they learned it more in training speaks more to our risk table, where in coding, we have 3 different components that really filter into that medical decision making. And so I always try to explain, first of all, that it's really apples and oranges, and for the coding purposes, there's lots of different components that go into, coming up with that medical decision making. So just going over the first part right here, this first slide is going to be the number of diagnosis or treatment options. And I know on some of your templates you may have different limitations on these, and again, it kind of depends on where you're at. I left these off just because I know that some of the ones that we've grabbed from different MACs have different numbers on them, and so I just left it blank. And certainly if you see this table, you can fill in where maybe your MAC will only allow 2 here, or for your new problem 3. So you may have limitations in this area. But it's really figuring out from that medical decision-making piece, what is self-limiting today? What is an established problem and potentially stable or improving, or maybe an established which is worsening? And then we have our new problems down here where no additional workup plan. So this may be a patient that comes in with, let's just say a sore throat and a headache, and they have a viral infection, and today, they're just going to go, the physician has recommended that they, just rest or do whatnot. Whereas that new problem, let's just, say if they had a finding of wheezing and whatnot, so they're going to go get a chest film to figure out if they have pneumonia. That may be the difference between no additional workup plan and additional workup plan, which you can see is reflected in the point system here. So as far as the results, the maximum is going to be 4 here. Oops. 4 here for tallying this up in the end, okay? So that's the first piece of complexity. The second is going to be the data to be reviewed. And again, there's lots of different areas in here as far as what they can get points on. And so review or order clinical lab tests. So it doesn't matter whether they review or order 1 or 10. They just get 1 point for it. This goes the same within the radiology section. The medicine section is speaking to that 90,000 series of codes in your CPT book. And so this is going to be your PFTs, EKGs, those sorts of things. Now, if the physician has the actual image in his office, even though, maybe the radiologist translated it, but he still is bringing the image up to go over with the patient, this would be the difference of reading a report versus looking at the image. You can see there's a 2-point value with this. And so, again, that's a really nice thing. If your providers oftentimes will bring those films up in their system. It's always good for them to say, I personally reviewed, just so that they're not saying X-ray showed, because that's a pretty subjective thing to say, to know whether they looked at a report versus they actually looked at the image. So there's lots of different things here, as you can see, that they can obtain points with. So I think this is a good revealing slide, again, for education, just to show how important it is to go through all of these and certainly document them if they were performed. The last piece of complexity is going to be the risk, and this is probably the most familiar from the provider standpoint, as far as how they determine that patient is minimal risk versus high risk. But from a coding perspective, this is the third piece. So we have to have all 3 of these, and I'll just show you the tally in just a minute, in order to come up with a type of decision making. So the way this table works, you have presenting problems, diagnostic procedures ordered, and management options selected. And then below here, you can see we have your level of risk. Now, the way this table works is that the highest of what you mark in any one of these areas will become your overall risk. So an example of that is, just say that a patient comes in for hypertension and it was stable and improving. So here we have one stable chronic illness, and let's just say that the physician adjusted the medication, maybe for the patient to take a lower dose. So we have prescription drug management here. So because prescription drug management is in the moderate category, the risk for this particular example would be moderate. Okay? And so as far as figuring out the type of decision and how it relates to CPT code, we have straightforward, low, moderate, and high. And so you must have at least 2 of the 3 components to satisfy any level of complexity. So you can see here in A, if I had 3 marks for maybe their stable problems that are coming in today, which the patient, which provider, evaluate. Maybe the physician looked at some labs today, and maybe the patient is on a high-risk medication, let's just say tamoxifen. So this might, in this circumstance, this would be a moderately complex patient as far as coming up with just the decision-making complexity piece. So that's how that works. And again, it's good to break these down individually if you're doing education, just to share with them how different it is looking at coding and maybe how they're looking at complexity from, just a medical standpoint. So this is probably my favorite slide, and just because I think it speaks to so many things with evaluation management, and certainly the very key piece of the assessment and plan. Now, one of the things we looked at with that first slide for number of diagnosis and treatment options, you saw under whether it was self-limiting, whether it was a new problem, or an established problem. You see some, I'm sorry, this just keeps moving on me. I'll try not to touch that again. You can see that as far as you're presenting problems for established diagnoses, it's so important for them to have something to say what's going on with that particular problem, because that could mean the point differential of something that is improved that receives 1 point, or something that maybe is not well controlled. That could be 2 points. And so rather than having a listing of diagnoses with a plan but no status, can really impact the complexity piece. And so, this is something that, especially if we're working in a hospital environment and we're looking at records where patients have multiple diagnoses that are assessed on a daily basis, I'm always really particular about saying, this is an area that, has to be one of those things that you're documenting for all of, your established diagnoses that you're managing. So again, a good slide to share if you're going to take some really important pieces away from this today. So visit complexity. This is always a really interesting thing to look at, and I think it's a great resource, first of all, in your CPT codebook. Back in the different appendices of the book, they have examples, clinical examples of different levels based on specialty. And granted, these are not means to an end, but I think they give a good idea for things that solely happen to a patient as to where that should fit in, assuming all the documentation fits in that also. So, I always like to pull out those examples and say, for a specific specialty, I'll actually divide them out and say, here are just some baseline examples to show you of what the AMA says, really should fit into these levels. And so that is a fantastic teaching tool. I think the bottom part is also, again, something good to look at as far as just the E&M misconceptions. Simply because a patient has a complex medical history or multiple problems, it doesn't mean that always will have the highest level. So something just to remember, there's a lot of things that go into all these different areas of E&M documentation and coding. So as far as the medical decision making, again, I thought this was really interesting too. CPT defines a self-limiting or minor problem as a problem that runs a definitive and prescribed course, is transient in nature, and is not likely to permanently alter health status or has a good prognosis with management and compliance. So, that is a pretty loaded statement. And what I recommend to our clients is that they sit down with their providers and say, based upon your patient panel and your specialty, tell me the things that are self-limiting to you. Tell me the things that are easier to figure out and really fit into this definition versus those things that are truly new problems, because there are some areas that it isn't so black and white. I mean, we do have those gray areas of diagnoses where it's very difficult for a coder to figure out, which is it. And so this is a good conversation to have with your provider. And I left you an example down there. So I put some tables together just to, and you have this in your CPT codebook, as far as just looking at, we have the criteria for new patients. And so the way, again, that this works is everything across, as far as your history, examination, and decision, must be met in order to meet these different levels. And within these tables also, I've given you the time, which we'll talk about after a short break, as in how that necessarily fits into, overriding the different criteria. And you can see here, especially for levels 4 and 5, there's, of course, a time differential. But as far as history and examination is concerned, they're identical. And the only thing that really changes here is whether you have a moderate or high complex patient. So important to remember for those, just distinguishing between those two levels. For the established, again, we talked a bit about the 2 out of 3. So, from an auditing standpoint, we will run these out of our auditing tool, but we always will trump the decision making. We do have some cases that we will, use just the history and exam, but I would say majority of the time we will, really run on the decision to say that it should be this level of service. And again, different companies have different ways of looking at it. We tend to be more conservative, so that's why. And you can see again here we have the 4 and 5 a little bit different. History is the same. Exam again being comprehensive here, detailed here, with the decision making changing from moderate to high. With the 99211, I do have a slide on this, and knowing that this is going to be a nursing visit or something very minimal, and maybe just that they're saying, why the patient is here, the medical necessity behind, that just very brief visit, and the body area organ system, that's probably going to be vital. And again, this decision just offering up if it's a Coumadin clinic or whatever it is, just that information. And you can see here with this 99211, the appropriate use and the misuse of it. And it's surprisingly, when we do a bell curve analysis with our different clients and we see a high level of 99211, we really dive into that, knowing that that's a really easy area for CMS to run that information off of, and mostly just to ensure that A, it's a face-to-face visit, and B, again, that there's medical necessity attached to it. And so, again, I've given you some examples of appropriate versus inappropriate use of that. And so here's how these guidelines work for initial hospital and observation. So this first series right here is going to be your initial hospital, observation, and same day admit discharge. And you can see the time differential is a little bit different based upon the category. The biggest difference with these different levels is going to be pretty much the decision making. And you can see if information is not at a comprehensive level, it's going to go down to the lowest level. So, and I do have a slide in here that talks a little bit about, what if it's lower than that. But most importantly, you have to have 3 out of 3 in order to use one of these codes. And then again, we have a requirement of 2 out of 3, and you can see here I have the subsequent observation, subsequent hospital. And again, just important to really focus on the medical decision-making piece. And actually, I have a slide right here that this was published by CMS several years ago, but I think it's an excellent slide for teaching just to see what they're thinking. And this is a little bit of a backwards way of thinking about these codes. So, first considering what does the patient have going on to decide, is the patient stable, recovering, or improving? And again, what does the documentation look like to that? I mean, you would assume if they were, one of these, that there's probably not going to be a comprehensive history, a comprehensive examination. And then this level 2, maybe the patient's not adequately responding to treatment or has a minor complication. Where these level 3s, subsequent, are really confined to those unstable patients or maybe something new, or, they're just very complicated. So I like this slide in that it just talks more about, what do you have first, and does the documentation match behind it? So this is the slide that I was referencing as far as if you have something less than the detailed level for initial hospital, what do you do? So in a transmittal published back in 2011, right after the consultation codes were eliminated, several of the MACs followed this guideline in that you need to defer down to the subsequent levels for the hospital. And so again, if they only have an expanded history, maybe a detailed exam with low decision making, because that history component was not at least detailed, you would go down to these levels of codes. And that's just what they recommended, because we don't have the 5 levels anymore. We only have 3 to work with, and the first one, again, makes a requirement that you have to have it at least detailed. So in any case, a good piece of information to know. And with that, Christina, I'm going to go ahead and pass it over to you for a quick demo.
Okay, wonderful. Great session so far, Jana. Let me go ahead and switch to my screen, and if you could just let me know if you are now seeing the coding suite.
I'm not. I still see my screen.
Lee? Or?
Yep, just went live.
Okay, perfect. Thank you. Okay, so we're going to take a quick peek at the resources available within our coding suite. I've moved into the Coding and Revenue Resource Center, which is our mid-level product within our coding suite. And in this solution, we're going to provide coding and reimbursement resources, tools, as well as pertinent regulatory content to support E&M coding. We do organize all of our content into libraries and collections, and we keep you abreast of what is happening in the industry and what's new to our product with our daily news alert. It is available on the product, but comes to you in email format, and this is going to be customizable based on the specific user selection of content, but keeping me abreast to all of the new changes that are occurring. Users can also set up custom alerts based on specific searches that they conduct and receive alerts on those as well. And then lastly, we also provide a weekly newsletter, which is our week in review, giving you a federal update every week as to what's happening in the industry. Now, we do give users a number of ways to access content throughout our product. And with evaluation and management coding and CBT coding in general, I always start with my Advanced Code Explorer, which sits up here in the upper left-hand corner. Here I can search for a series of codes. I can actually search on terms, a range of codes, or a number of different codes. This is going to search CPT and I-9 today simultaneously. We do have an ICD-10 Code Explorer, or an ICD Code Explorer, I should say, and I'll show you that just momentarily. But with this particular coder, what's quite unique and valuable is the fact that it's an advanced coder pulling together coding and coverage information, reimbursement, and compliance guidance into one view. So for the specific particular codes that I'm showing on screen, I can go right to my codebook to see the catalog of coding content that we have within our CPT and HCPCS codebook. There I'm going to see all my AMA descriptions. I'm going to see my chapter and section guidelines, which in many instances are going to include coding tips. As I scroll down this page, you'll see I have parenthetical guidance. And then for each of the codes, this one particular has a lot of CPT assistant references, I have national payment information. So based on the particular codes that I've selected, I can expand out to see the relevant payment information for that particular code. We also give you all the transmittals, so we've searched behind the scenes the transmittals for that particular code, and we're going to surface those. In this case, there were quite a number for this E&M, this basic E&M code 99211, 93 hits, and we'll give you links right to those transmittals. We do the same with our LCDs. This is going to provide information from the MACs based on your selection of states, and so it's going to give me direct access to that coverage information for the states that I have chosen. And then lastly, the last link you see underneath that code description is going to be to my coding guidance library, and this is giving me access to a variety of CMS references as well as CPT Assistant, the Insider's View, and in our top-tiered product, the AHA coding clinics as well. Now lastly, on the Code Explorer screen, you'll notice some payment information on the right side, both for hospital outpatient and particularly for physician fee schedule. This is leveraging our RVU Calculator, where I can actually launch and see an adjusted payment rate for a facility that I have chosen. I can actually launch into the RVU Calculator from the Code Explorer. So here it's pulled in my single code that I had selected, but I can also open up a blank screen and search on a series of codes. And so this is going to simulate a number of codes simultaneously, giving me that locality specific, based on my selections, payment rates. And for codes like my radiology codes, where I'm going to show you the professional technical split. But we do give you some key fee schedule indicators and the ability to see the full detailed calculation by expanding the view. So now I can see the actual RVUs utilized in the calculation itself. So quite a nice calculator to have access to. As I mentioned earlier, we also have an ICD Explorer that helps you navigate both I-9 and ICD-10 coding and the mapping too. Let me just type in a term. So this is going to allow me to search both code sets simultaneously. We do have the CMS gems included, both the forward, backward, and reimbursement maps, and I can use the little mapping buttons to actually crosswalk if I needed to see how I code crosswalk from previously from I-9 to I-10 today, or going backwards even. So that mapping button is going to show me that relationship utilizing the gems. In addition, this is a tool that we very recently enhanced in anticipation of the implementation date, in enhancing it, giving you those same very similar links that you just saw with the CBT Code Explorer, where here I can access the ICD-10 codebook for that particular code range, see all the chapter or expand the chapter and the section guidance, and see that code structure. We do expand out and show you every reportable code in bold, and which then sometimes makes those pages a little bit long. As we all know, the code set is quite large. So I have the ability to collapse it if I want to jump down a section quickly or see that in an expanded view. In addition to the link to the codebook, there are additional links like the LCDs, very similar to what I just showed you with CPT, where we're surfacing any LCDs that have already mentioned these codes, coding guidance, and as well our MSD Definition Manual, which is a new publication that we just created to support ICD-10 navigating through the DRG system. So that's our ICD Explorer, which is, again, another nice tool to have at your your fingertips, I should say. Back on my home page, I have access to a number of other resources. I wanted to point out particularly the under Codebooks and Guidance, direct access to all of my codebooks, so I can really just browse through that codebook, turn the pages as I'd be accustomed to doing. But also wanted to point out the E&M guides. The E&M guides is accumulation of information from the various MAC sites. It's in a nice table format. It is going to include both your 95 and 97 documentation guidelines for evaluation management services that Jana was just speaking about, audit enforcement information, including OIG reports, tools, etc. So that's another nice resource, just accumulating all of that content into one location with quick links to that information. And then lastly, I thought I'd point out our CMS manuals. All of our CMS manuals are archived. We provide a lot of archival, a lot of content within the manual, so I'm going to navigate into a particular chapter. We'll go into the physician chapter 12. And as I navigate into my chapter, you'll notice the dating in the sections there. We're telling you that last update to that particular chapter, and we'll highlight for red specifically what in that section had been modified. What's also really helpful when you are doing audits is to be able to go back in time and see how a manual read at a particular time. And so with our archiving, we've tucked away a prior version of that manual. So if I am doing an audit that is dealing with 2011 dates of service, I can see exactly how the language, exactly what was communicated by CMS at that point in time. So the Coding Revenue Resource Center, again, is our mid-level product, giving me access to a lot of coding resources, tools, reimbursement resources, as well as regulatory content. So I'm going to go ahead back over and turn the program back over to Jana so she can finish out her presentation, and then we'll open up for questions a little bit later.
Thank you so much. That was really helpful. All right, let me go ahead and share my screen and get back to where we're at. All right, so let's continue into time-based services. So starting with discharge, and I wanted to bring this up for a couple of reasons. We do a lot of audits through the hospital, so with hospitalists, pulmonology, intensive care, all different kinds of things. And this is one of those codes that sometimes feels really easy to use, but actually it can get complicated pretty quickly as far as just meeting the guideline. So as you well know, there are two codes that talk about discharge services. We have the 238 and the 239. And really the only difference being is that 239 is over the 30 minutes. And so most important to meet that is just there's some documentation that says over 30 minutes was spent, or 40 minutes, or, there's different ways of saying that. But that is one of the requirements in order to justify that code. The second thing that is going to be very important is the face-to-face care. And now different hospitals, have rules as to what is required for a discharge services. And sometimes we see exams documented, sometimes we don't. Sometimes we will see like the patient course of history of when they were in the hospital, and what's happened since. And so it may be very hard to determine whether there was any face-to-face without the provider either doing an examination or commenting on the conversation that they had, or something to that nature. So again, really important just to ensure that those two pieces are documented in order to do a discharge service. And this was a great Q&A that we found. What information does the physician need to show in the medical record to support a face-to-face visit for the discharge management? Several of our physicians indicate stable and improving, no vomiting, tolerating diet. Would these statements show face-to-face? And the answer from CMS was no. The statements listed above could have been obtained from a nurse note or chart. They do not support a face-to-face service. And so that is how they're viewing this. And that is the importance of either doing that discharge exam, whether it is in that discharge or maybe earlier in a subsequent note, which is completely fine. But in any case, I think it just gives a lot of insight that this is an area that they are looking at to audit, and we have found lots of issues with it. And so it's a good, again, a good slide to share with providers if they're in the hospital frequently. So let's talk a little bit about counseling and coordination of care. And if you remember on the tables that we just reviewed, I gave you the codes, but I also gave you the time that's associated with it. And throughout the CBT section, E&M section, you'll see that a majority of the codes do have time associated with it. You do have codes that have no time associated. For example, emergency room is one, or the preventative health visits don't have time. So, this rule is very specific to those E&M codes that have time associated with it. So if a provider has a patient that, let's say, follows that, maybe they, in their initial visit, they were recommending some type of treatment, and so they're following up today just really to talk about that treatment and the course that they're wanting to take. So there may be an interval history to state that the patient is following up for this problem, and this is what we recommended the last visit. They may or may not do an interval examination, but a majority of the visit is the conversation with the patient and really talking about, questions that needed to be answered and maybe the decision that the patient has. And so, that piece is super key to meeting that guideline, the actual counseling and coordination of care that took place on that visit. The second thing is the time. And again, MACs have totally different opinions on how time should be documented. So I will just speak from our MAC and how they have asked us to do it. And, they don't give a really objective way that they always want it this way. But, if the total time is documented and a percentage, for example, spent a total of 60 minutes with the patient, over half of which, or a majority of which, or 50% of which was spent on counseling the patient on these different things. And again, that can be in the note in many different ways. But those three pieces of information, the total time, the actual counseling time or percentage, the content of the counseling, are all required in order to meet this guideline. So as that follow-up visit, you can look at it first maybe on the audit sheet to say, based on the elements of today, maybe this was a level 2, just based on the E&M elements. But, for this follow-up visit, the physician documented, the 20 minutes, and half of which, more than half of which was spent doing the counseling. So just that in itself, with all this information documented, may very quickly switch it to a level 3, meeting that 15 minutes, but not quite the 25 minutes needed for that 99214 if it wasn't established in the office. So the counseling and coordination of care is super valuable, and there's many specialties that, spend a majority of their follow-up visits just doing this. And it's not there's not a distinguishment which specialties can and cannot use it. And so, again, it is available, and I always, tell our clients, if they're doing it, then code on that. Just make sure these elements are documented. So in any case, it's a little bit on just this first part of the time-based. And I give you a nice example here just to show you, what is required. And as you can see with this example, I have the times associated with these established times. And for this patient, the 20 minutes was spent with the patient counseling on treatment options for chemotherapy. So in any case, something nice to be able to share. So the other part of the time-based that we often will talk about is prolonged services. And prolonged services is just a little bit different than just the counseling and coordination of care, because prolonged has specific codes that are identified with it. And so there's several sets. You have a set that is specific to outpatient services, and you have a set that's for inpatient services. And aside from that, you have face-to-face care and non-face-to-face care. Now, those face-to-face and specifically non-face-to-face, the definition has changed several years ago as far as when you can code the non-face-to-face. So that code now can be used. Let's say, for example, a patient was transferring from an out-of-state hospital to an oncology practice, and the oncologist spent 20 minutes reviewing the records, documenting the history, because he's going to visit with the patient, the next day. So that particular visit, that non-face-to-face time where he has documented that, can actually be billed, assuming, he does provide that documentation. Now, the other question is whether the payer will actually pay for it. So, there's always that linking up to whether it's worth doing if your payer does not reimburse for that. But first of all, there's that distinguishment between those two codes. Let me just give you an example for the hospital and where this code can be particularly useful. So with especially hospitalist practices, they have shift changes. They may be on for 12 hours, and different parts of the day they may have a shift change. And I'll just give the example of a shift change going on, let's just say at 5 at night. And so earlier in the day, the hospitalist visited with the patient and documented their visit. Well, the new provider, also hospitalist, comes on at 5 o'clock. And later that evening, it's required for that physician to also see the patient. And so we have two of the same specialty, same group, seeing the patient for a problem. Well, if you look at the regular guidelines, you know that we can only bill for one subsequent hospital that day. But if the first provider adds time, how much time they spent face-to-face with the patient, and the second provider does the same thing, you could actually add the entire services together to see whether or not 30 minutes over and above the published CPT time was met in order to code the base code, which would be the subsequent code, and a prolonged visit on top of that. And that's a way to capture that charge. Prolonged service can be put on any level of evaluation management service that has time associated with it. The requirement being that, again, there has to be at least 30 minutes over and above that time. So there's lots of different scenarios with this. That clinical example I felt was a good one, just because we run into a lot with our audits. If you have more questions on that, you can certainly ask in the panel, or get a hold of me directly, and I can tell you more about that. So let's move into our last couple of sections. First of all, ancillary staff and scribing. And prior to this webinar today, I did have a caller that had sent in a note asking about the CMS guidelines changing as far as what they can and cannot document. And to my recollection and to my knowledge, I don't believe anything has changed. I did go out and, of course, look at all my links prior to this several weeks ago. But the way the guidelines read right now is that ancillary staff, this is your medical assistants, RNs, can document review systems and past family and social history, whether it's on a form, in the EMR, but everything else needs to be done by the provider, whether it's a physician, PA, nurse practitioner, DO, et cetera. So that's quite important. You know, sometimes when we have conducted audits, and the wonderful thing about these EMRs nowadays is that everything can be signed depending upon who's on that part of the record. And so, you know, there's been times where we have found that other staff, ancillary staff, has, you know, taken the history of present illness and signed off on it, and there really hasn't been any editing done by the provider. And, you know, that gets to be a really kind of a questionable situation when they are not technically scribing for that provider. So in any case, just important to remember that, you know, even though it's been easier as far as just having an EMR and multiple people that can be in there taking information, that those are really the two areas that they should be documenting. Move on to this next slide as far as scribing. So another situation that we have found in our auditing is, you know, sometimes we will go into a health system where very clearly a medical assistant has taken down all of the information and the provider has co-signed. And again, this is, you know, scribing is very much based upon the MAC and, you know, some state regulations that weave into that. So in our experiences in the states that we have worked for, scribing can only be done by somebody that is designated just to do that. So if they have other medical responsibilities as a medical assistant or whatnot, they can't technically be a scribe. And there are very specific things that have to happen within that document, whether it is electronic or written, as far as just ensuring the guidelines are met, to just go through the scribing information, authentication, and then, of course, the physician's oversight and signature. I've given you a basic template. I would highly recommend, if this is something that you are doing or considering, that you do check to ensure that wherever you are in the United States, that, you know, you're meeting the guidelines that are set out by that MAC. Because, again, this is an area that we find a lot of providers get in trouble with, as far as feeling like that's a more efficient way to run their practice, but at the end of the day, it's not compliant. So a good thing to look at. So one of our last areas is going to be shared services and incident 2, and I'm going to pause after this section to allow questions to come in. The industry news and whatnot, those are things that certainly you can look at and read on your own, and look at the hyperlinks. There's a lot of interesting things in there. So shared services and incident 2. So the first thing to mention with the difference between the two, shared service really is speaking to inpatient services. So there's really not a guideline that speaks to shared services for a clinic, place of service 11, unless we default down to the incident 2, which we'll talk about. So a shared split visit includes a mid-level, so it would be a nurse practitioner, a PA that is working with a physician on a patient. So in the hospital setting, it may be that the PA or nurse practitioner rounds on patients. They document their visit no different than the physician would. So maybe later on that day, the physician is following up in the hospital and also doing rounds on the same patient. And they would look at the documentation that was performed earlier that day and possibly annotate anything that they agree, disagree, or anything new and different about that patient. Now, from a documentation standpoint, in order to ensure that the shared split visit requirements are met, the physician has to document at least one area to include history, exam, or medical decision making. So very legitimately, they could say, I personally saw and visited with the patient, agree with the exam from my nurse practitioner today, and maybe re-annotate the medical decision-making place, going over those diagnoses, and talking a little bit about just the treatment that's set forth. So, and again, we've worked on several litigation cases around the country, and very interesting on how the interpretation of this. And so again, we recommend that there's a standard set forth by a health system to say, if you're doing the shared service, in order to grab that 100% reimbursement versus the 85% for CMS specifically, that that requirement is met as far as documentation. The physician has to do one of those areas in order to complete it. It cannot be just a sentence of visited with the patient, agree with my nurse practitioner, agree with assessment plan. That doesn't work. And oftentimes we will find that because maybe they've been in a teaching setting and certainly overseeing a resident or whatnot, the PATH guidelines are very different as far as showing supervision. The shared split visits really speak to collaboration, and that's an important distinguishment between those two areas, especially if you have systems to where you're not only looking at the PATH guidelines in order to bill services that way, but you're also dealing with shared services where physicians and nurse practitioners or PAs are working together. From a discharge standpoint, discharges can also be a shared service. The only note to that is that, again, there has to be a face-to-face visit done by both providers. And the reason I mention that is once in a while we will find that, the PA does the discharge summary and starts it, and then maybe the physician will review that, on the system and then make notes to it, but there's no evidence that they also saw the patient. So, again, an important point to remember, and I do have a slide here that that speaks to that. So a good thing, again, to review really carefully, certainly rely on your MAC Q&As. We found a lot of wonderful ones out there that are specifically to this. And the last thing is just talking about incident 2. So this would be, I suppose, the shared service in the office, if you want to call it that. There's similarities, but very different components of this. So this is specific for place of service 11, and so if it is a hospital that is maybe provider-based, employs providers, and they've set them up as outpatient departments, incident 2 would not apply in most of the states that we've looked at, which is quite a few. Again, always check with your CMS intermediary to make sure that that is the case. But for the 3 items that are required for incident 2 services, so it is somebody who's employed, okay? And so they give you in the guidelines several different employment arrangements, W-2, a lease employee, etc. The service must be under direct supervision. And so this means a provider needs to be in the office and immediately available. It doesn't mean it's personal supervision where they need to be in the room, and it doesn't mean general supervision where they may be across the street at the hospital. So they have to be in the office suite. And the third thing is the diagnosis must be established by the provider or group. So if the patient is following up, for example, for, let's just say it's a rheumatology clinic, and they are following up for rheumatoid arthritis, but today they have a horrible headache and stomach pains, and so this is something new. So that would automatically make it so that it wouldn't even fit into the incident 2. It has to be diagnoses that are established, and that's all that's going on today. Now, again, different MACs have talked about if a plan of care has not been established or changes, then they won't consider incident 2. Other MACs have said something different. So this is one of these kind of funny things with the payers that it's all over the board on how they interpret this. And this is really specific to CMS. So, there are Medicaid that absolutely do not recognize this. There are private payers that don't recognize this. And so, again, it's just knowing the payer guidelines very well to understand who actually will, take incident 2 services and pay for them, or if they require all of your providers to just go on their own MPI for that purpose. So hopefully that distinguishes those two different things. So Lee, why don't we open it up to questions for the last 10 or so minutes and go from there.
Will do. Christina, can you take over the question duty here?
I can, absolutely. Jana, so we have a number of questions, so let me start at the top here. We have a user or a participant who asked about physician assistants and their role, obviously, with the provider. The primary provider should be the one documenting their role in the procedure, but they were curious about your opinion on having the physician assistant dictate a brief note to make sure that they can capture those services. Is there any precedent
So
there,
are you saying that so they're participating on a procedure, but yet the physician is billing?
The physician assistant is participating or assisting in a surgical procedure, and
gotcha.
There are thoughts about dictating, having the PA dictate a brief note.
Okay. So that's actually a good topic. There are differences in modifiers with the whole 80, 81, 86 series, and then an AS, as opposed to like a co-surgery. And for something like this would probably fit into just the 80 series of surgical assist. So the requirements that have been set out historically have been just that provider saying that PA assisted. But I think it's always good affirmation to say, if that's what they want to do as a standard of care, having that PA, say a piece of that, I think that just bulletproofs that assist piece and certainly justifies maybe an 80 over an 81, or for Medicare it's always going to be AS. So I think that's really up to the health system to decide if that's going to be just their standard of care to ensure that that piece is captured. So I think it's a good idea, but I have to say that I don't see it very often, but that's a great question.
Okay, great, thank you. How about, must the provider, we've had a number of questions about chief complaint, and one of them is asking, must the provider document the chief complaint, or may it be documented by other clinical staff? And then I had other individuals asking about RNs being able to document that chief complaint. So what are your thoughts there?
Yeah, so, with EMRs it's really interesting because you have the integration of a couple of things going on. At the reception desk, you have, sometimes them documenting the reason for the visit, and sometimes on the back side that will fill in the chief complaint, which can be quite controversial because, sometimes you'll find that what patients tell the receptionist or tell the person who's scheduling them versus why they're actually there can be very, very different. And again, this is one of those things where I would highly rely on your MAC to say what they should do. If you have somebody else just saying why the patient is there today, I still believe that in the history of present illness, that physician should affirm, why that is. They shouldn't take for granted that that's documented by another person. I think that they should always ask the question themselves, and again, that will just bulletproof the documentation that they have done their history of present illness and they're confirming that chief complaint. So that can kind of go either way, and I kind of just take that on a situation-by-situation basis, and certainly what the regulations are for that state to ensure that, again, if someone were to grab that record and audit it, that it would meet the guideline.
Okay, thank you. On the topic of non-contributory for review systems or personal family history, does Noridian accept? Are you aware of Noridian's acceptance? Is that acceptable?
As non-contributory?
Mm-hmm.
No, it is not. Yeah. So in the audit situations that we have been involved in, supporting that provider, that it is sort of a reviewer-specific question, but more often than not, they have not counted it. And so that is one of the reasons we put that in here, as far as just training providers, that if they did ask something relevant to today, it's better to say what they asked or what they reviewed versus putting non-contributory.
Okay, great. Thank you. If a patient has been seen by one provider in the office and then comes back and sees another provider for the exact same problem, is that considered a new problem to the second provider?
Well, that depends on specialty. So, and again, getting back to that, the medical decision-making pieces that we looked at as far as a new problem versus an established, the MACs have had opinions on this as far as if it's the same specialty and they're following up with a partner on a problem that has already been documented, then more often than not, we have seen MACs say that that should be an established problem because it's the same. They're coming in for the same thing. They're just following up with a different physician, same specialty. If it's a separate specialty and it's a new problem, well, certainly that's going to change a lot of things. And first off, figuring out is it a new patient to that specialty? Have they been to see them before in the last 3 years? And have they covered this problem with them before if they are established? So that can have lots of different, I guess, variables in answering that.
All right, very good, thank you. Does the decision to remain on the same medications qualify for prescription drug management?
Yeah, it seems like we get this question every year. And again, when we go to the FAQs and different MACs, they talk about this a lot. If they are actively managing that medication, so maybe they have, labs that are speaking to whether their Coumadin should be adjusted, or, their diabetic insulin, or whatever it is. As long as they are actively managing that medication, that can be counted. If they're just saying things that they're on, but not necessarily actively managing, that's a different story. So again, I would default to your MAC again, because we've seen several different things on this, but just in the majority we have seen the word active management used to say that, again, if they are participating regularly on monitoring that would be considered, the medical management. If they are not, then, probably not. That's a great question.
Okay, great. Let me see what else here. Let me see. Providers are wanting to capture the exam component with a level 3 E&M visit when also providing an annual wellness exam. Would it be appropriate to bill a problem-focused E&M if the patient has multiple chronic conditions that are stable, the physician is continuing prescription drugs with little or no changes, and ordering screening labs?
So, that's a really interesting question as far as just how to divide out that preventative versus medically necessary piece. If a physician spends a lot of time on those medically necessary portions that require him to do an examination, focusing on that and redoing medications, very legitimately that could be an E&M. And I always try to tell our clients, if you just spent a few minutes, going over things that really relate to, the medical necessity piece, and it doesn't take a lot of time, I kind of put it in their court as far as, whether was this just simple enough to where I should just bill the preventative? Was it enough to where I really had to, examine differently? I had to, document and, prescribe out new things. So, what I like to do with our family medicine and internal medicine is pull records and just look at that and say, let's look at the different scenarios to say, when these preventatives take you a lot longer, because truly and honestly, we're dealing more with the chronic problems versus the preventative piece. And so that's a great analysis question to where, we do spend a lot of time pulling individual information to decide, should this visit even been preventative anyway? I mean, is it just a follow-up on chronic problems versus, is this their annual wellness, and did we cover, some other things? If you are using the annual wellness codes as far as the CMS stuff, they very clearly say, if you do cover something that's medically necessary that is outside of the question, guidelines that are put forth in those codes, then yes, you should bill in addition to. So it kind of depends which way you're going, and again, if it's CMS versus the private. So great question, but it really does require sort of that individual attention to what's going on.
Okay, great. Thank you. This one's pretty straightforward. When we have a hospital-owned physician practice, so provider-based clinic, therefore they see patients that in the hospital setting that are established in our clinics. Would we bill these as initial new patients?
No. So if they are, so if it's an internal medicine practice, which of course is functioning as hospitalists and also have them as clinic patients, the first point of contact with that patient, if they first saw them as in the hospital and then again they're following up in their clinic, that would be established at the clinic. So that's a really good question, and we covered that a little bit in the beginning. So it's the first face-to-face contact with that provider regardless of place of service.
Okay, excellent, thank you. I think we have one on time-based services. Let me look at that question here. When billing time-based services, would the verbiage majority be accepted, meaning greater than 50%?
And yeah, that's a great question. And you know what? In the audit situations that we have been in, it has worked. If they say, 20 minutes was spent with the time, a majority of the time was spent, doing the counseling or coordination of care, and then a full description of what that entailed. With those three pieces, we have found that has stood ground. And we haven't been in a situation where that hasn't, so I guess I can put it that way.
Okay. Okay, great. Let me see here. Give me 1 second. Trying to scroll through these. There's a lot of questions. And we may not get to all of them, and we'll certainly address those offline as well. I think we may have already talked about that, but can an RN be a scribe?
Mm-hmm. Well, again, from the states that we have worked in, scribing has been said to be a sole position where that is their function. So they really do not have other functions as far as taking intake forms or vitals or anything like that. They are truly just a scribe. But again, I would be pressed to say that is consistent for every state. So my recommendation would just be to check with your individual MAC. If they have specific opinion on scribing, you need to work with that. But most of the time, and I'm just trying to think of an instance where they were not able to do, or they were able to do more than scribing, and I can't even think of one. All the states that we've worked in where this has come up, that has to be their sole responsibility.
Okay.
But as far as being an RN, that doesn't make a difference. I mean, if they want to hire RNs to be a scribe, I think that's a great idea, just because they understand, more of what the provider is saying, and they can probably do an awesome job of documenting. So I don't think it necessarily means who the person is or what their credentialing is. I think it has more to do they do anything else in the clinic besides scribe?
Okay, very good. If a provider states that they discussed the risks and benefits of a diagnostic procedure, like an endoscopy, for instance.
Oh, can you just say the first part of that, Christina? I'm sorry, you cut out when you were.
Oh, I apologize. If the provider states that he discussed the risks and benefits of a procedure, so like a diagnostic endo, would you consider that as a high risk under the bullet point diagnostic endoscopies with identified risk factors?
Well, so as far as like signing consent and talking about the risk area, there's three areas I think in the low, moderate, and high as far as just with the risk factors mentioned. I have to go back to the risk table. In fact, I can go ahead and go back here right now. Let's just look at that. Here we go. So we have minor surgery with identified risk factors or elective major surgery. And then again, I guess it just depends on what kind, because there probably is going to be some things that are going to fit, with endoscopy as far as being minor versus something major and elective. So I guess we would have to get a better example to say what were they doing, and based on that, would it fit into a moderate or high category? They also have these minor surgeries with no identified risk factors, and so maybe it's just taking off a lesion or something. But again, that's really going to depend on what type of endoscopy and what they're doing inside there.
Okay.
Hey, and Christina, just to be mindful of folks' time, let's make this one the last question.
Okay, that sounds good. And it looks pretty straightforward. Is a chief complaint required on a subsequent visit, and if so, may it be taken from the assessment and plan?
That's a really great question, and absolutely, it needs to be included anytime there is a visit with that provider. So, and with that question, I sort of feel like maybe that came from somebody who's working in a hospital environment. If it's a subsequent visit on a patient that you're continuing to take care of, it's still going to be pertinent to say, seeing the patient again today for kidney failure, things are better today. But just giving that interval history to tie into the assessment and plan. And I'll tell you what, when we have defended providers on subsequent notes, that has been a key issue. If the judge or whoever we're working with has not seen that interval history to tie into that, they're missing a huge piece of one of those two things, especially if they have a very limited exam. But secondarily, sometimes the whole picture is not in the assessment and plan. There's lots of things that can be gathered from just that interval history and a new review of systems daily as that patient is making progress or declining or whatnot. So super important to make that individualized every day. That's an excellent question.